Hello everyone, this is Dr. Hamid Ashraf, Associate Professor and Director, Rajiv Gandhi Center for Diabetes and Endocrinology, Aligarh Muslim University, Aligarh. Today we are going to discuss a case of established cardiovascular disease. Here we have a gentleman, a 53-year-old corporate executive diagnosed with diabetes 6 months back. When he came for routine checkup, he complained of weakness. His family history was positive for myocardial infarction, hypertension, and he is a heavy smoker for last 30 years, but he has left it 5 years ago and has been trying to lead a healthier lifestyle. He also has history of he has history of myocardial infarction 3 years back. On physical examination, weight was 92 kg, height was 5 feet 8 inch, BMI of 30.7, which is obese, and blood pressure was 140 by 90 millimeter of mercury. And laboratory investigations reveal HbA1c of 8.4%, LDL cholesterol of 137, which is raised in this patient, HDL cholesterol of 37 milligram per deciliter, and triglyceride of 156 milligram per deciliter. A renal function test revealed EGFR of 65 ml per minute per 17.3 meter square. Urinary albumin creatinine ratio is 50, which is also slightly on the higher side. Drug history: currently patient is taking metformin 1 milligram twice daily. He is also taking telmisartan 40 milligram once a day, atorvastatin 10 milligram daily, amlodipine 5 milligram per day, aspirin 81 milligram per day, and clopidogrel 75 milligram daily. The patient-centric approach to management of this patient will include cardiovascular protection, microvascular protection. As he is obese, we need to reduce his weight also, and we need to reach glycemic goal without hypoglycemia, and the dosing of the medication should be convenient to the patient because he is a executive and he may need to travel, and many times he will not be able to take multiple medication at the same time. So primary consideration is cardioprotection to optimize glycemic control for CV risk reduction and address any weight issues. By adding SGLT2 and DPP4 combination, benefits received are cardio-renal protection, simple regimen, early and durable achieving the glycemic goal, and weight loss and less chances of hypoglycemia. As you know, the cardiovascular disease is the leading cause of morbidity and mortality in adults with type 2 diabetes mellitus, with its onset estimated to occur 12 to 15 years earlier in people with type 2 diabetes mellitus. The excess risk for this atherosclerotic cardiovascular disease in patients with type 2 diabetes has been estimated to be at least twice that of without diabetes. The Framingham Offspring study, which included around 2,000 patients, suggested two-thirds of the patients of type 2 diabetes mellitus have subclinical cardiovascular disease. Diabetes mellitus increases the risk of subclinical cardiovascular disease by almost 4.3 folds, and subclinical CVD increases the risk of CV events by more than twofold. The vascular wall in patients with diabetes is well known to have advanced atherosclerosis. The EMPA-HARD study, which is the effect of empagliflozin on cardiac structure, function, and circulating biomarkers in patients with type 2 diabetes mellitus, has shown that empagliflozin results in early significant reduction in left ventricular mass regression, which was detected by cardiac magnetic resonance imaging, and also suggests that to reverse the cardiac remodeling may be possible contributor to the cardioprotective effects of SGLT2 inhibitors. In 2015, the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPA-REG outcome study, which has demonstrated significant benefits of empagliflozin for CV mortality by 38%, as well as MACE that is major adverse cardiovascular outcomes events in type 2 diabetes patients with CV disease. All types of CV deaths were reduced with empagliflozin. More prominent absolute benefits were observed for heart failure related death and sudden deaths. The post hoc analysis of EMPA-REG demonstrated that consistent CV mortality benefit irrespective of the prior CV events, MI or stroke, heart failure burden, CKD, baseline HbA1c level, control of multiple CV risk factors, or background use of metformin. Several mechanisms have been proposed for the CV effects of SGLT2 inhibitors, including osmotic diuresis, natriuresis, leading to blood pressure lowering, decrease in arterial stiffness, vascular resistance, decrease in weight, decrease in uric acid, and oxidative stress. It has also been reported that SGLT2 inhibitors promotes a reverse cardiac remodeling, improves myocardial energetics and filling conditions, and reduces left ventricular wall stress, and mass and reduces the blood pressure and arterial stiffness. The Heart Cardio-Link 6 study demonstrated that empagliflozin could produce early reverse cardiac remodeling in type 2 diabetes and stable coronary artery disease. In Carolina and Carolina trial, linagliptin has also demonstrated CV and renal safety of linagliptin versus placebo or active comparator when added to standard care in patients with type 2 diabetes who are high risk of vascular complication. The Ampalina is available as first-in-class treatment in SGLT2 and DP4 combination group of drugs. At 24 weeks, Ampalina, that is 25/5 milligrams, showed a statistically significant HbA1c reduction of -1.08% from baseline of 7.99%, which was statistically significant as an add-on therapy to metformin. The HbA1c decrement by Empalina has demonstrated 1.81% HbA1c reduction at the baseline HbA1c of more than 8.5% at 24 weeks. The combinations offers a suitable component in the strategy to achieve target HbA1c without hypoglycemia and weight gain in patients with high baseline HbA1c level together with cardioprotective benefits in patients. That's all. Thank you very much for your patient listening.